Assalamu alaikum, sabah al khair, good morning. First, I'd like to thank the organizing committee for their very kind invitation. It is a privilege and honor to talk to you today on autoinflammatory disorders. And I'll just share my slides first. And these are my talk plan. I will discuss with you the concept of autoinflammation, its genetic and pathogenic basis, its clinical spectrum, and I will end with treatment approaches. And these are my disclosures. The concept of autoinflammation dates back to the description of hereditary periodic fever syndromes, which happened in early last century. And it was characterized by recurrent episodes of fever and inflammatory attacks at certain locations, such as peritoneal cavity, pleural cavity, or joints. They are monogenic disorders with an ethnic predilection, and they are usually named according to their prevalent area, such as familial Mediterranean fever, or FMF, is more common in the Eastern Mediterranean countries, and similarly, familial Hibernian fever or familial Dutch fever were named because of their geographic connections. Firstly, the gene responsible for FMF was identified in 1997 by two groups and named as MEFV, which encodes a protein called pyrene. And at that time, the function of pyrene was not known. But 2 years later, the gene responsible for the second hereditary periodic fever syndrome, familial Hibernian fever, was identified as the gene encoding TNF receptor 1. And this syndrome was associated with, again, fever attacks and some additional findings lasting a bit more, 7 days or more, such as migratory erythema, periorbital edema, fasciitis, arthralgia, and myalgia. And after the identification of the gene for this hereditary periodic fever syndrome, Dan Kastner and colleagues from the NIH called this condition as an autoinflammatory disorder, just to differentiate it from autoimmune diseases because of the characteristics a bit different from autoimmunity, because they are associated with unprovoked episodes of inflammation without contribution of adaptive immunity. So absence of high titer autoantibodies or antigen-specific T lymphocytes were characteristics, and they were associated with inborn errors of the innate immunity. And the third gene responsible for hereditary periodic fever syndromes was NLRP3, or at that time NOD3. And this gene was actually causing, at that time, 3 different clinical settings. The simplest one was familial cold urticaria, which is the mildest form of the spectrum. And the second one is Ahmet syndrome. And the third one is the most severe form, starting early childhood and causing a multisystem disease, neonatal onset multisystem inflammatory disorder. And this was actually a different clinical pictures described at that time, but they all were connected to one gene, NLRP3. And these conditions were associated with fever attacks and also urticarial rash, ocular findings, epiphyseal overgrowth, meningoencephalitis, and sensory neural hearing loss due to cochlear involvement. And now we have a growing list of several monogenic and autoinflammatory conditions inherited as an autosomal recessive or autosomal dominant disease. And among them, familial Mediterranean fever, which is the most common condition described so far, especially in our parts of the world, is still the leading monogenic autoinflammatory condition among many others. And each year, another gene responsible for an autoinflammatory condition is being added to the list. So this is a growing list. And now we have a spectrum of inflammatory condition. At the one end of the spectrum, there is rare monogenic autoimmune disease part, which is a very rare condition, such as autoimmune lymphoproliferative syndrome, or IPEX or APESET syndrome, are located in this spectrum. And But in the other end, there are rare monogenic autoinflammatory conditions, including FMF, TRAPS, mammal nut kinase disease, PAPA, or NLRP3 associated periodic fever syndromes. But in between to these rare conditions, there are many common disorders with features of either autoinflammation or autoimmune diseases. And within the polygenic autoinflammatory disorders, there are several conditions we are seeing very frequently in daily practice, such as Crohn's disease or crystal arthropathies, including gout, pseudogout, and some reactive arthritis or idiopathic forms of uveitis, acne-like, or acne-associated conditions, erythema nodosum. And there are also some conditions named as mixed pattern diseases, especially actually class 1 associated conditions, including ankylosing spondylitis, Behçet's disease, reactive arthritis, and psoriatic arthritis are located in between these rare monogenic autoimmune and autoinflammatory disorders. But after the first description of the condition, the terminology a bit changed after observing several both monogenic and also acquired forms of the autoinflammatory conditions. And these changes included, first, the attack part of it. It was originally described as episodes of seemingly unprovoked inflammatory attacks, but it was noticed that vaccinations, infections, trauma, cold exposure, especially for the NLRP3 associated conditions, exercise or stress can induce an inflammation. And for the absence of autoimmune pathology without high titer pathogenic autoantibodies or T cells, now we have some evidences showing that there may be a T cell activation or polyclonal hypergammaglobulinemia in some patients, which is developing as a secondary phenomenon on top of hyperactive innate immunity. Now we have a broader definition, including those conditions associated with abnormally increased inflammatory response, usually manifesting itself as recurrent attacks, and they are usually mediated predominantly by the cells and the molecules of the innate immune system. So this description does not rule out the contribution of autoimmune components. And there is a significant host predisposition. So the original autoinflammatory conditions are monogenic, but there are some complex or polygenic forms of autoinflammatory conditions as well. So the first autoinflammatory condition, FMF, and many others are associated with inflammasome activation. Inflammasome was described in 2002 by Jörg Schaub and colleagues as an intracellular cytoplasmic multiprotein complex with a receptor, usually recognizing a danger or pathogen-associated signal, and then causing an assembly of multiprotein complex called inflammasome, which activates caspase-1, and the active caspase-1 then proteolytically activates IL-1 beta and IL-18. So inflammasome activation is responsible for the proteolytic activation of IL-1 beta and IL-18. And there are many conditions directly associated with increased inflammasome activation. We call them inflammasomopathies. The pyrene inflammasome is the original, the first described form, and the FMF associated gene pyrene is associated with mutations, especially in exon 10, which is the hotspot for classical recessively inherited FMF. And there are also another area which is associated with dominant MEFE variants, which is a bit rare. And there are other regions of the protein which are associated with some functional polymorphisms. And the pyrene protein is also interacting with PST-PIP1, and that is associated with PAPA syndrome, which is another rare autoinflammatory condition associated with pyogenic arthritis, pyoderma gangrenosum, and acne. And the third one associated with pyrene is mammal nut kinase gene. That one is encoding the enzyme called mammal nut kinase, and deficiency of these enzyme functions is resulting on previously known as hyper-IgD syndrome. and they all are connected to pyrene-associated inflammasomopathies. But inflammasome activation can also be due to node-like receptor-associated receptors, including NLRP3, NLRC4, NOD2, or CART14. And these proteins are associated with different conditions in addition to NLRP3, as I described to you. NLRC4, for example, is associated with hereditary forms of macrophage activation syndrome, and NOD2 is associated with Blau syndrome, or in adults as a complex disease, Crohn's disease, and CART14 is associated with psoriasis. But in addition to this classical definition of autoinflammatory disorders, there are some additional forms of autoinflammatory conditions. And the second one is autoinflammatory disorders with some autoimmune features. And these are exemplified by interferonopathies. So excessive production of type 1 interferon, which is an innate cytokine, but its excessive production is leading to the development of autoimmunity. And also autoinflammatory disorders with features of immunodeficiency is another part. For example, PLCG2 associated antibody deficiency and immune dysregulation or play syndrome, or DADA2 deficiency of ADA2 enzyme or RIP kinase deficiency are causing both autoinflammation and immunodeficiency. And regarding interferonopathies, they all are associated with increased type 1 interferon production due to mutations in proteasome components or some other interferon pathway genes such as STING. And the clinical picture is a bit different from type 1, inflammasomopathies, which may include vasculitic rash or lipodystrophy, meningoencephalitis with some calcifications, bony changes, pulmonary changes, but especially vasculitic involvement is a very typical feature of these interferonopathies. And the clinical picture may mimic to congenital viral diseases, which is another cause of increased interferon production. But in that case, the clinical picture is developing without any viral stimulus. So it is an independent production of type 1 interferons. And another inflammatory pathway may be associated with enzyme deficiencies. It might be RIP kinase or ADA2 deficiency. And the best example would be ADA2 deficiency because this is directly associated with a congenital form of polyarteritis nodosa or early onset lacunar infarcts or cerebrovascular disease, livedoracemosa, and PAN-like features are typical characteristics findings of this ADA2 deficiency. Regarding the clinical picture, especially for the classical and the most common ones, we have some distinctive features which may really be helpful for the clinical evaluation. It may include the duration of attacks. For example, it might be 1 to 3 days for FMF. It might be more than 7 days in TRAPS. For mevalonate kinase disease, it might be around 1 week. For CAPS, depending on the disease severity, which may be a few hours to a continuous inflammatory response. But if you have a genetic finding, some distinctive features may be enough to confirm the diagnosis. For example, for mevalonate kinase disease, in the presence of a confirmatory genetic finding, gastrointestinal symptoms such as nausea and vomiting, and cervical lymphadenitis and after stomatitis may be enough to confirm the diagnosis. For TRAPS, if you have a confirmatory TNF receptor SF1A genotype, at least one clinical finding of a longer duration fever attacks, 7 days or more lasting fever attacks, myalgia, migratory rash, or periorbital edema, or a family history may be enough to confirm the diagnosis. And for CAPS, on top of genetic findings, urticarial rash, red eye due to conjunctivitis, episcleritis, uveitis, and neurosensorial hearing loss is enough to confirm the diagnosis. These monogenic autoinflammatory conditions usually start early childhood, so early onset is very important. But there are some adult cases, so which may be really important for internists and rheumatologists, adult rheumatologists. Well, these adult onset patients may be due to a late diagnosis of the actually early starting manifestations, or it may be associated with variable expressivity and incomplete penetrance of disease-causing variants. So some of the variants may show incomplete penetrance and the disease may start a bit late. And there are definitely low penetrance variations in the MEFE, MVK, or TNF receptor SF1A or NLRP3 genes. And these low penetrance variations, or even their combinations, may be associated with an autoinflammatory clinical phenotype, which may not be typical for each one of these known conditions, but you can sense that there is an autoinflammatory feature, and which may start a bit late, and the manifestations may be overlapping, but it may give us a flavor of autoinflammation. And there are some patients with some atypical features, which may be associated with new conditions. And there are, of course, multifactorial or complex mimics of these monogenic forms of autoinflammatory conditions. And lastly, there are some somatic variations causing autoinflammatory disease phenotype. Regarding the low penetrance variants, for example, in the MEFE gene, proline 669 serine, or in TNF receptor 1A gene, R92Q, or in NLRP3 gene, Q703K, are very well-known low penetrance variants. And these variations are associated with adult or childhood onset recurrent inflammatory attacks with manifestations of fever, fatigue, arthralgia, myalgia, arthritis, after stomatitis, cervical lymphadenopathy, pericarditis, some ocular findings, including uveitis, or some skin findings, vasculitic or urticarial rash or papulomacular rash, or in addition to acute phase response with neutrophilic leukocytosis. So these overlapping manifestations may be associated with some low penetrance variants in the autoinflammatory genes. So for the diagnosis, we need a genetic testing. Sanger sequencing for selected genes or exons may be enough, especially if you are working in an area where FMF is the most prevalent condition. But nowadays, next generation sequencing for several genes involved in hereditary autoinflammatory conditions is the preferred way of screening. Since it is allowing a deep sequencing of these genes, it is possible to catch some of these somatic mosaicisms as well. But for some patients with totally unknown or yet not described conditions, whole exome or whole genome sequencing may be the better choice for the identification of novel genes. But identification of a variant is not enough. It is necessary to show its functional importance, because most of these variations are either benign or likely benign. So it is necessary to confirm the pathogenic role of these variations or their direct involvement with the clinical phenotype. So after the identification of the pathogenic pathway, autoinflammatory pathway, it is possible to develop or to plan a tailored treatment depending on the disease severity and the involved pathogenic pathway. For inflammasomapathies, colchicine is the treatment of choice for FMF, and previously it was known to be effective only in FMF patients. But now, after the identification of these low penetrance variants, colchicine may be effective even in these, some of these low penetrance variants. And for refractory patients or those who are not responding to colchicine, IL-1 inhibitors is providing the best solution because there are inflammasome-associated conditions, and these conditions are associated with increased IL-1 beta production. So anakinra, canakinumab, or rilonacept are the preferred choices. For interferonopathies, since they are associated with increased production of type 1 interferons, now we have a drug inhibiting interferon signaling, JAK inhibitors, all JAK inhibitors, may work in this condition. So there are some data showing the efficacy of baricitinib and tofacitinib, and I will show you one example. In patients with interferonopathies, you can see the clinical changes before treatment or after baricitinib treatment. There are clear differences in skin and other manifestations of the disease. And this response is usually start very immediately. And whenever you start these treatments, the blockade of responsible cytokine signaling is usually resulting in clinical improvement. And the third choice might be using anti-TNF or bone marrow transplantation in patients for DADA2. DADA2 is associated with enzyme defect in ADA2, and this defect is resulting in increased adenosine activation, which is causing increased TNF-alpha production from monocyte macrophages, and also increased activation of low-density granulocyte by the release of NETs. So NETosis is contributing to the clinical picture. So in patients with lacunar infarcts or vascular findings, anti-TNF agents are the preferred choices, and starting anti-TNFs are usually resulting in stopping all vascular findings. But depending on the residual ADA2 activity, if there is no residual activity, these patients are characterized by bone marrow failure or pure red cell aplasia. So in those patients, the preferred treatment is bone marrow transplantation. So after the identification of the gene responsible for the disease and the pathogenic pathway and the clinical severity, you may decide what is the best option for these autoinflammatory conditions. So in summary, autoinflammatory disorders are a group of clinical conditions associated with abnormally increased inflammatory response without obvious autoimmune pathology, and they are usually presenting us with self-limiting attacks. And these attacks are predominantly induced by cells and the molecules of the innate immune system, especially myeloid lineage. And most of these patients are harboring some genetic variations. So monogenic forms are the dominant forms. It may be either penetrant or low penetrant variants or complex pathologies, but there are some multifactorial cases as well. And recently we are learning a lot more about somatic mosaicism. So thank you very much for your attention, and I would be more than happy to answer your questions.